Joining LASA OMS for our webinar, Highly Responsive but Often Overlooked Injuries, Knee Pain Edition, featuring Chad Bond. My name is Jeff Bloom, Education Marketing Coordinator here at LASA OMS. LASA OMS strives to support our customers, practitioners, educators, and other industry professionals through quality products, product education, and school and humanitarian relief donations. With our free webinar series, we intend to offer product and practice management education through its practical application by some of our industry's most educators. Keep in mind, if you are not able to join us for future programs, we record each webinar and make the video available on our blog afterwards in the following week or two. Let me also take a moment to acclimate you to the webinar room. To the right of the video screen, you will see 3 tabs: Chat, Questions, and Polls. To ask a question of our guest speaker, please post it to the Questions tab. To chat with other attendees during the webinar, please use the Chat tab. It is also best to use Chrome, Firefox, or Safari browsers to view the webinar, as you may experience some slowness on other browsers. We will attempt to answer every question during the course of the webinar, but in the event we cannot, answers will be shared on our blog afterwards. Now for the main event. I'm going to introduce our guest educator, Chad Bond. Chad is an acupuncturist who specializes in sports injuries and pain, practicing at Philadelphia Sports Acupuncture and the University of Pennsylvania. He has completed master's degrees in both exercise science and Oriental medicine, and has studied extensively with Whitfield Reeves, one of the leaders in acupuncture sports medicine, since 2007. Chad is a contributing author to the Acupuncture Handbook of Sports Injuries and Pain, and also co-authored articles that have been published in multiple acupuncture journals. He has assisted Mr. Reeves in teaching seminars all around the world and for the Acupuncture Sports Medicine Apprenticeship Group. Chad teaches classes at the One Institute and previously at the Tri-State Acupuncture College, and also just continuing education on sports acupuncture and orthopedic assessment in Florida. Lastly, I wanted to mention that Chad and a group of his colleagues have teamed up to create the Sports Acupuncture Alliance. They are preparing 3rd annual symposium that is featuring renowned speakers such as Dr. Arya Nielsen, Dr. Clayton Shue, and Derek McBride. So join them in Philadelphia. It's going to be April 5th to 7th, and we'll be there ourselves. And we'll make sure to include links in the chat tab. We are thrilled to introduce Chad Bond.
All right, thanks for saying hi, everybody over there on the, on the chat side. I saw lots of names I recognize, and definitely some that I do not. So thanks for coming. A little nervous. We're gonna pull up my slides here, it looks like, and then we'll get rolling. So actually, the universe has been nice to me recently. Once we came up with this idea, I've had a couple of really good stories that fit what we're talking about tonight. Patients I've seen, and they fit this title exactly. They responded well. First, the injury was overlooked. The specific injuries that we're talking about today by whatever other practitioners they saw, athletic trainer, doctor, whatever, and it was easy to figure out, and it was they also responded very quickly. So fit the title very well. It's a little weird to not have any feedback. For those of you who've had classes with me, I like Jack, so this is a little bit challenging for me, but I'll try to roll. All right, so here we go. How do I move forward here? All right, so for those of you who have not had a class with Whit or I'm just going to quick roll through kind of Whit's 4-step approach. This is kind of the basis of the sports acupuncture book that I helped Whit with. And it's kind of his outline of how to think through a treatment. Now, obviously, you don't have to do every single one of these things, each technique. Otherwise, you'll end up with a million needles in somebody. But it's a way to think through where you want to put some needles, how you want to think, how do you want to set up your plan. So the initial technique or initial treatment, the first technique in there is tendinomuscular, which would be just a bleed of the Jing well on the affected meridian. Just a quick quick hit with the diabetic lancet. The tradition is 10 drops of blood, and then sometimes you can get a pretty dramatic response from that. So the best example is probably the hamstring stuff we'll talk about. It's pretty consistent with somebody who has a hamstring issue, that if you take care of their jing well, you can get a significant increase in range of motion or decrease in pain pretty quick. Opposite side, we really won't talk about much today because we're going to go mostly on local side. Opposite extremity, kind of the same thing, but they are steps you can about. So if maybe somebody has something that's really, like they sprained an ankle and it's really swollen and you don't want to go in there, you can go over and do something on the opposite side or opposite extremity, either one, and try to get some quick change in how they're feeling. This initial step is like trying to make a change really quick in the first like 2 minutes that you're treating the person. If it doesn't work, you just move on to something else. If it works, great. Then you're already a step ahead in your treatment. Sometimes with that hamstring thing is you bleed that jing well and you get such a change. People are blown away by getting 20, 30 degrees change in their hamstring flexibility from you doing one thing toe. Caveat is it can be a little intense for some people and you have to explain the whole bleeding thing. So new patients, sometimes that's challenging. Empirical points, occasionally there's an empirical point for a specific injury. One of the classic ones would be like stomach 38 for frozen shoulder. So we could talk about using them. And then step 2, the meridians and microsystems. This is where we kind of get into typical acupuncture kind of stuff. Shoestring point combination is something that we'll talk about for sure today and that I use a lot in my practice. So it would just be using the shoestrings on the affected channel and its paired meridian. So if you're treating the stomach channel, then you're also going to treat the large intestine channel. So needling the shoestrings. Traditional point categories, that's all of your like antiquity points and things like that. And we'll talk about some of them. And I'm sure you've all spent a lot of time studying those in your time in school. So I don't think we need to go into that too much. Somebody just put jing well for the hamstring UB67. Yes, that is correct. You pass for the day. Extraordinary meridians. We might talk a little bit about them today, but mostly we're going to talk about like doing the die meridian and things like that to open stuff up for the hips. Microsystems would be like ear acupuncture or Korean hand acupuncture or whatever microsystem you want to use. I once had a teacher who used my Achilles tendon as a microsystem. That was fairly intense. I don't use that. Needling through my Achilles tendon. Internal organ imbalances is not something we'll spend much time on today, but you guys have the skills to go and do a nice TCM or whatever type of acupuncture you're using, do a good diagnosis with that and add this to whatever treatment that we talk about tonight. So, and then local site of the injury, that's mostly what we'll talk about today, and how to go about finding the local site of the injury and how to go about treating it. All right, on to the other stuff. All right, so Pez Anserine bursitis is the first one. So I just had a case of this that was classic for what we're talking about here. Patient who I'd seen 4 years ago, a very avid runner, has run for 20 or 30 years, had taken a couple weeks or a month off, I think, from training, rested, recovered, went back to running, was training for a half marathon, which she's run multiple full marathons before, so it wasn't like she was jumping into a huge amount of training. And she ended up with some medial knee pain, went to her doctor. Her doctor took an x-ray, didn't see anything on the x-ray, but diagnosed her with a tibial plateau stress fracture. So came into my office basically wondering if I could help with that and to treat her hip problem that she has a history of. And I started kind of checking out her knee and palpating around, and right at where the doctor probably found pinpoint tenderness, which would point us towards possibly a stress fracture idea that we'd want to look at. But the pinpoint tenderness was on a mushy, soft thing, and it wasn't right on bone. It was on mushy, very spongy kind of surface, and it happened to be right exactly where, you know, the pes tendons are coming down, just below the joint space of the knee, basically right where that pes bursa would be. So I was like, well, I didn't tell her, like, you don't have a fracture, but in my head I was like, well, I think this is a good chance that this might be a pes bursa thing. Did this treatment that we're going to talk about today, and just like advertised here, it was highly responsive. When she came back for her second treatment, she was like, I don't have any pain anymore. So, which is great. It's exactly what we want. And it wasn't anything brilliant. It was just poking around at the thing that hurt, which sometimes the most simple things are awesome. So that was my most recent case of this particular problem, and it's responding very well. I see her again, I think tomorrow or Friday, I think. So we'll do a little bit more. So pes Anserine is basically a tendon. Pes Anserine basically means goose foot. So it's 3 tendons come down and sitting over the top of each other, and they attach, you know, to the tibia, and they're coming down. It's the sartorius, the gracilis, and the semitendinosus. And you can see those muscles kind of coming down here. And they all attach onto the tibia, and there's a little bursa. Actually, there's 2 bursas that sit under. There's the pes bursa, and there's musculi sartori bursa, but they're mostly just called the pes Anserine bursa, and they sit underneath those tendons, and basically they can get angered fairly easy. I see it a lot in runners. This is also a problem that's very common in overweight patients. It's extremely common in people who have osteoarthritis of their knee. It's actually, I think I put it in the notes that you guys will get. I think it's like 75% of people who have pes Anserine bursitis also have something else going with their knee. So you can't just treat the pes bursitis. You got to figure out some other things that might be going on. But often, if you just clean up the pes Anserine issue, the other picture becomes much more clear, and you're able to solve the other stuff. Now, I'm treating this a lot with runners and athletes, and you know, cleaning up pes often cleans up a lot of it, but then you probably got to go up and check out the hips and things like that to get them working as well. But they don't have, you know, severe arthritis, and they're usually, you know, runners are not overweight, you know, patients. So they don't, my patients aren't necessarily fitting into that category, but I'm definitely seeing this on a regular basis. All right, so typically they have pain in the medial aspect of the knee, just distal to the knee joint space on the medial side. So if you want to find your knee joint space, you find the bottom of your patella, you move medially from that, and you'll feel basically like a ridge with, like, it's basically 2 mountains in a valley is essentially what I want you to feel for. And you can kind of flex and extend your knee a little bit, and you'll feel that space open and close. And then you can palpate all across where that knee joint space is. I'll show you a picture of a knee joint space here in a little bit. I can't use my cursor, can I? All right, so anyways, so that bursa is just below that knee joint line, right on where you can kind of feel those tendons of your, you know, hamstring, semitendinosus, or so the semitendinosus, the gracilis, and the sartorius coming down, which I'll show you a video of where they're at in a few minutes here. All right, this can happen from a direct impact to the bursa, or this can happen from, you know, changing your training. This can happen from, you know, activities where there's a lot of cutting, you know, changing direction. I'm distracted by all the communications over here on my right-hand side. All right, so tight hamstrings, tight gracilis, tight sartorius, or an injury to those muscles is how you're going to get here more often than the direct impact to the bursa. I got this from walking my brand new puppy. He was about 2.5 pounds when we got him, and by the time he got big enough to actually go on a leash and walk, He was all over the place, and I was avoiding trying to step on him, because if you step on a 3-pound dog, it's pretty much game over. So I was trying not to step on him, and I'd walk around, and eventually I had this just sharp shooting knee pain on the medial side of my knee, and it ended up being Pez Anserine bursitis, and it's pretty easily treatable. I was basically working with WIT at that point, so it was pretty easy to make go away. It was my personal introduction to Pez bursitis. All right, moving on to the next slide. All right, before we get into the treatments, I'm going to share my screen here, and I'm going to pull up. I'm going to just pull up a video. All right, so here's basically a shout out to kinesiotape. Here's some kinesiotaped muscles. So basically, this is your sartorius running up like this. This is your gracilis kind of running up from the medial knee up to the pubis bone or pubic bone, and then this is your semitendinosus kind of going into the back here, sitting on top of your semimembranosus in there. All right, you guys can see my cursor, I hope, when I'm drawing on this. So easiest way to find this or feel this is to start up at the ASIS, have them slightly lift their leg. Oh, sorry, start at the ASIS, go 3 soon, essentially down from the ASIS. So you're essentially at like stomach 31-ish. Put your finger into that space. Can you see me? And then have them lift their leg. And what you'll feel is a V pop up, or a valley sitting underneath your finger. And on the lateral side of that valley, you're going to feel the TFL, or tensor fasciae lata, deep underneath your finger. That's where your rectus femoris is. And then on the medial side, you'll feel an angled muscle. That's going to be right here. And it's going to be your sartorius. So that's the easy way to find the top of the sartorius. And then you can kind of palpate down from there. Often, especially if you're dealing with an overweight kind of population or a heavier population, it's going to really disappear in this middle space. So you probably have to come down here and also find it down at the bottom. Let's pull up a different video. All right, so here's another video, me actually trying to find this stuff. So here's me starting up at the ASIS, come down a little bit, have him lift his leg. You can feel the muscles pop up on the lateral side, TFL, on the medial side, sartorius. And then underneath your fingers in the valley is rectus femoris. You can see the rectus femoris on Alex, and you can kind of see his sartorius coming down here. Alex is a pretty fit individual. So you can kind of just palpate down there. You can kind of even see my fingers snapping across here, right about there. Look at that. You can see my fingers snapping across his sartorius. All right. So you can palpate all the way down. On most people, it's going to disappear here. So then you're going to have to come down and start at the other end. Come on, Chad. Start at the other end here. All right, here we go. All right, so you want to find that group of tendons right there. And if you push down anterior to posterior at those tendons, you'll feel the edge of the sartorius, so the most anterior of those 3 muscles. And then you can palpate up from there and basically meet your 2 hands in the middle. Okay, so that's how you find the sartorius. Let's move on to the gracilis. Gracilis is, all right, so it's finding the gracilis. So we're going to find the sartorius, and then we're going to bounce across off the sartorius going posterior essentially. And then that next muscle over that you feel, it's also a thin ropey band of a muscle. You can palpate up and you can feel that one as well. And then the last thing you'll do is you'll come back and you'll now start at the posterior aspect of all those three tendons. And then you'll follow that, and that'll get you up in here to the semitendinosus. Semitendinosus down here, that tendon I'm on right there before, that's semimembranosus tendon that goes down further as far as an attachment. And we want to get the one that comes down under the tibial plateau there, and then palpate that, and you can follow it up, and it basically comes up into here. All right, let's pause that. Close that video. All right. Go back. How do I get out of here? Hi. You all still there? Did you get that? Feel like I lost contact there. All right. So diagnostic-wise, there's no brilliance here. This is kind of medial knee pain, pain that's sharp, stabbing, and comes and goes. And often it's just from palpation. All right. So I palpate right down there at that pes bursa, just at the end of those tendons, and I just look for a really tender spot. They'll often say, that's it, that is my problem, very tender. You can go over to the other side, as long as they're not complaining of medial knee pain on the other side as well. You can go over there and pick that exact same spot on the other side and compare the difference between the two. I don't have a lot of tests for this, certainly not ones that fit very well with this type of class. You know, you could manual muscle test, the sartorius, the gracilis, the hamstring, you know, the semitendinosus. Semitendinosus is pretty easy. Gracilis is not that hard either, but sartorius is definitely a challenging muscle to do a manual muscle test. Probably not perfect for this particular situation. So those are options. You can Google those manual muscle tests pretty easy. I have probably a description I could send to you somehow as well. But mostly this is just a palpation of just down there palpating and finding that bursa. Things that we want to kind of check out to see if they also have these problems, or if, you know, differentiation of disease, right? I want to, you know, do they have some arthritic changes in their knee? This is probably something that they'll come and tell you that they have. Maybe they've had an x-ray or the doctor has diagnosed them with this. You want to check to see if they have MCL, medial collateral ligament sprain. Sprain? Yeah, sprain. You could do a valgus stress test to test that as well. I think that's all we want to really differentiate from this. And then, you know, sometimes you can get a little bit of, you know, maybe tricked by a little bit patellofemoral joint issue as well. But that's going to be more underneath the kneecap. Probably is not going to be that far medial. But if they're just really swollen in that area and you're dealing with, you know, a patient that's a little heavier, you may have, you know, to figure out where that swelling is in there. Is it on the, or is it underneath the kneecap, or wherever? So, but reason why I picked this as a topic to cover is it's pretty easy to find. You just go, you palpate just below the medial knee. There's not a lot of tissue. It's going to be really painful there, and you poke around in there and it's really tender. That's probably it. And then palpate up those three muscles that we just talked about and see if you can find really tender stuff along those muscles. All right. So that's pretty much, you know, a simple diagnosis for this. All right. Moving on to treatment for this. So liver 1 is probably the only gyn well that I would consider bleeding for this. I don't typically, although it fits into a lot of things as far as like, you know, standard, you know, clearing heat, because this will be warm, It'll probably be a little swollen on them. So maybe clear, heat, drain, damp kind of, but mostly since it crosses, basically all three of the yin meridians are going to be involved in this. I'm not just going to bleed the liver. I'm going to come up and do, local stuff and then treat spleen, liver, kidney points distally. Opposite side, you could try, liver 8's pretty close to there. Kidney 10's pretty close to there. Spleen 9's pretty close to there. Those would actually be 3 points of almost surround that tissue. If you wanted to be in pure acupuncture points, that would be a great probably way to go about it. Opposite extremity would probably be lung 3, lung 5, heart 3 kind of area. Special clerical points, medial knee pain, liver 3 plus pericardium 6. Liver 3 on the affected side, pericardium 6 on the opposite side. So those are things you can try like right away to see if you can get them to work. If they don't work, it's okay. Just move on to the next thing. All right. So once we get to the shoe streams, you kind of got a lot to choose from here. I think all of these are probably part of this. And I may just needle liver 3, spleen 6, or sorry, liver, spleen 3, kidney 3, all in this patient anyways, because all of those muscles are, all those meridians are involved with these muscles. But if I'm going to do a shoe stream combination, I'm probably doing liver 3, pericardium 7, maybe spleen 3, lung 9. Additional point categories, liver 2 plus liver 7 would be a good combination to put in there. Spleen 6 I like just because it's the crossing point of these 3 meridians that run through here. So I'm definitely using spleen 6 on this. I'm also probably using spleen 9 because it's an inflammation kind of problem. So I'm going to try to, they clearly, especially on the people who have this really chronic and, it's really swollen in there. You can see a lot of, edema, well, not edema, but you can see a lot of swelling going on there. I'm going to want to, do things to drain damp as well. I'm probably not using that extraordinary meridian, but, the yin chow mai. All right. I do not do anything with microsystems for this particular problem, but you could try some auricular therapy for the knee if you want, if auricular therapy is your thing. You could also just do pain points with auricular stuff. I'm pretty much, those of you who've had classes with me probably are laughing at this slide already. But basically liver 3, gallbladder 34 is like a staple in my practice. I do a ton of musculoskeletal stuff, and I think liver kind of controls muscles, and the gallbladder 34 is the influential point of tendons. So when you're dealing with muscles and tendons, that's a great combination. All right, so step 4, getting into this actual tissue and needling around this tissue. So I will find the most tender spot on that, and you could even put a mark there so that you know where it's at. And then I basically just surround it with 4 needles surrounding that dragon. Surrounding the dragon is basically the technique. So I have a needle on each corner, and I'll show you a video to demonstrate that. And then palpate up the sartorius, gracilis, semitendinosus, looking for Osher points, tender points, and then you're going to needle into that tissue. And I'll show you how I go about doing that. And then adjacent points, this person probably also has some glute issues going on. So this would be a great time to test a glute medius, glute maximus, and then go up there and do some point of the hip. Those of you who studied with Witterai, Jian Qua is basically our favorite point in the hip. So those of you who've not had that class with me, I guess I should explain where that is. So you find the widest point of the greater trochanter and then the highest point of the iliac crest, split that in half, and then you should be kind of in a little bit of a valley right there, and you kind of can push in. And then if you push anterior to that, you should feel the nice ropey solid band of tissue that is the tensor fasciolata. And then right where your fingers are, there should be a valley, and then it should kind of just slowly rise out into glute medius, eventually into glute maximus. But that should get you into some nice, good glute medius tissue. I think a few people on this chat over here could attest to what putting in 1 or 2 needles into a glute medius, letting it sit for 5 minutes, and then pulling it out and seeing how much stronger glute medius can get. I know a couple people should be saying yes. I've seen some names on here. Thank you. All right. And that's just, you know, testing it, seeing how strong it is, putting a couple needles into the Jian Qua point, pulling them out a couple minutes later, testing that tissue and seeing how much stronger it is. So I just did this in a class weeks ago, put in a couple needles, pulled them out. I guess it was probably 3 weeks ago now, pulled them out. They tested stronger, came back the next week, and this person tested a one-legged squat on this person, and they were a mess. Like, they were all over the place. Put those needles in, took them out, tested it. She was stronger. Tested her one-legged squat, much better. Came a week later, and she's like, look at this. And she's just standing there doing one-legged squats. She was so excited about it. And that was a week after having a needle in somebody for 4 minutes. It was crazy. Talking about the knee, and I'm way off on Jian Qua already. So, but great point. Thank you for all of the yeses over there in the chat. Appreciate it for backing me up. All right. All right, let's get to some videos. I'm going to go back to sharing some videos here, and we're going to talk a little bit through this. I know I'm supposed to be moving along a little faster. All right, let's see here. Pes muscles. I already found the muscles. So let's going up to needling them. Actually, we're not quite ready for that, maybe. Let's see. All right, so let's back up a little bit. So we palpated down here and found this tissue right here, and you could see that when I was palpating, right, that it was really snappy right there. So I'm going to come back and I'm going to needle that. So I'm going to talk a little bit about how I needled it. So definitely have some arteries, nerves, and veins that are flowing underneath this area. So you don't want to go deep with this needle. You want to know where you're at. You want to feel the tissue you're needling through. So what you're going to do is tap the needle in, go through the subcutaneous fat, and you're feeling for that first layer of fascial tissue. And then you're just going to run into that first layer of fascial tissue, and you're going to stop, right? So tap the needle in. Actually, I'll tap 2 needles in. So you'll notice that this is basically what I do. I tap 2 needles in, basically to the same muscle tissue, kind of in a line that's almost, I'm trying to basically be in the same fibers. And then I'm going to do this again. Sorry about the grainy footage. All right, so tapping another set of needles in here. I'm going to cruise through this since we already did this. And then I'm going to come back. Now I'm finding, palpating up the gracilis, find another nice tender spot in there, in a snappy kind of band of tissue. Tap my needles in there. Same thing, I'm going to tap the needles in. And then I'm going to put another second needle in there. And I just, see how I haven't pushed any of these needles in yet? I've just tapped them in, just put them in deep enough that you're able to, like, they're not just hanging down. And then I can still palpate without causing the person pain. It's a great trick. So if you're not used to palpating around muscles with needles, you can put the needles in, don't put them in all the way, you can still palpate around the tissue. All right, let's fast forward this. This is basically me palpating up that posterior aspect of these 3 tendons, getting up to the semitendinosus, tap those needles in. All right, let's cruise through this. I want to come into where I'm actually placing those needles. All right, here I'm actually placing these needles, I think. All right, so going through subcutaneous fat, which there's not much there, and then I'm running into that first band of dense tissue. And then I'm just going, I cut myself off. I'm just going to go into that tissue. I'm not going very far. That muscle's a thin muscle. So you don't want to keep just pushing through that muscle because you do have some vasculature underneath there. The femoral nerve kind of splits off and goes in a bunch of directions before it gets to that point. But there is nervous system underneath there, and there's definitely femoral artery and vein underneath there. So you don't want to go in there too deep. You could feel for a pulse before you put the needles in there if you're worried about it. But just stay superficial. Just get into that muscle, and that's as far as you want to go. All right? All right. Close that video. And all right. All right, so let's find that as bursa. I'm going to use that as kind of my top. All right, so this line right here is the medial joint space. So you have patella here, bottom of the patella, and then just going medial and posterior to that. This is the line of the medial joint space. These tendons are right here. And then, Alex doesn't have this problem. So, this is just, I just made up a spot where he was tender. So it's going to be somewhere around there. And then I'm just going to put in 4 needles kind of surrounding this tissue. Okay? You don't need to go smashing through the bursa. You can kind of just run up in, next to it and stop and let the e-stim kind of do the work to go around it. All right. While I'm putting in that last needle, I'm just going to talk about the electric stim. So once we got, all of our sets of needles in here, we can put e-stim on, basically the tissue that you thought was the most interesting up here. So I'll have, e-stim here on, these 2 needles. Black, red does not matter. Most of these machines are biphasic at this point. They're just going back and forth. They're not going around in a circle. All right, so I have e-stim here, and then come down here, and I'll have e-stim on this needle and on this needle. Let that go for 7 to 12 minutes, and then I'm going to take this, move it to here, or whatever other tissue I thought was the most important tissue. So sartorius, gracilis, semitendinosus. And then I'm going to switch to the other set of needles down here. All right, so that's basically my whole local treatment. And then I have spleen 9, spleen 6, liver 3, spleen 3, maybe kidney 3. We can have a conversation about not using kidney 3 on high-level athletes who are or high-training athletes who are going to burn through all their kidney energy. It's a very wit thing to say. But all right, pull up a different video here. All right, Pez e-stim. All right, I saw some e-stim questions already on there, so I'll try to answer that. But all right, so as you can see, I'm using the e-stim 2 machine. You can use whatever e-stim machine you want. This is just a simple version. I have them in a bunch of my clinics, and it's just what I use because I do a really simple version of e-stim, and I basically just have it set at my hertz are actually slowing down as I go. So my frequencies will say 4 to 10 hertz at this point. Somewhere in between there, to me, there's no magic number. I know as EM grows and people do more research on it, we're getting if you turn it to this frequency, you get exactly this, neurotransmitter or hormone or whatever dumped into the system. That's not what I'm thinking. I just want it going slow enough to get some, ions running into that tissue and get that muscle to slowly contract and relax. I need to go slow enough that it has time to contract, repolarize, contract, repolarize, contract, repolarize, to help get that muscle to get out of that state of contraction and to draw attention to that tissue. All right, so we're talking 4 to 10 hertz, and then I'm on millicurrent. If you have really good eyes, you can probably see millicurrent, microcurrent. You know, I know there's a ton of discussion about this. I was taught by Whit. Whit taught me millicurrent. That's what I use. I have played with microcurrent many times. I think I can get things, you know, I think things change with either one of them. So if you really like one or the other, go ahead. If you've never tried millicurrent, play around with it. If you've never tried microcurrent, play around with that. See if one works better for you. My personal feeling is I get more out of my muscle work with millicurrent, and if I'm really working with a nerve that I think is an issue, I switch to microcurrent. All right, so let's play this video. So I'm into the sartorius. So what you're going to see is when we turn up this E-stim, you can see this twitching here, and then if you come down and look at this needle, this is also in the sartorius, and you can see that that needle is bouncing as well. And then I can put my hand down here, and I can feel, you know, that tissue contracting all the way down to right at that tissue that we're talking about today. All right, and then if I went up this way, I could feel it going up to the ASIS as well. All right, so that's what I use to make sure that I'm on the right tissue when I'm doing this kind of stuff. You can switch. You can try the same thing on the gracilis. You can try the same thing on the semitendinosus. So I'll actually hook those needles up, try it, see if it works. If it doesn't work, I'll play with my needles a little bit, but I'll fuss around and get that in there perfectly and make sure it works. If you're a pointer plus kind of person, you can definitely use a pointer plus. Just, you know, put your needles in there, touch that, you know, see if you can get the muscle to contract. I don't use a pointer plus. Maybe I'm just not comfortable with it yet, or whatever. But I like just hooking my machine up and going with it. I don't treat with a pointer plus, and I don't test with a pointer plus. But I definitely see the value in testing one needle with a pointer plus to make sure it works. All right. All right. All right, I think I got that covered. Now I need to hustle through the other one, I think. All right, we good with the PEZ there? I will post, or we're trying to post all of these videos. Either they'll be on Lossa's website, or however Jeff does this. If not, then I will find a way to email you guys my Vimeo account, you know, well, not my Vimeo account stuff, but how to get on my Vimeo page, and you'll be able to see these videos, the full videos, not just the ones I just showed you there, but I have probably like 20 minutes of videos that you guys can use to look at this stuff. All right, on to the hamstring. All right, here's our hamstring. All right, so the story behind this one is basically, we're not talking about typical hamstring issues. We're not talking about belly of the muscle injuries. We're not talking about, you know, at the top up at bladder 36 at the ischial tuberosity. Those are really common. Nobody really mistakes those. You know, they're figured out all the time. But the distal hamstrings, so this stuff down at the bottom by the knee, is often just missed, is thought of as something else. Today we're going to kind of talk specifically about the biceps femoris, but it could be any of the hamstring tendons that come down there. You could have just, you know, an irritation to that tendon tissue, tendinosis, tendon whatever, you know, tendinopathy you want to call it. Usually because we have some issue going on with the hamstring muscle itself, pulling on that tissue, creating an irritation to the tendon tissue, and they're having knee pain. And they're having, you know, knee pain, usually posterior or lateral knee pain that they're complaining about. And people will think it's a bunch of things. They'll think that they have, you know, it's just arthritis that they're having a problem with. Really creative people might be thinking it's a plantaris or a popliteal muscle, you know, Baker's cyst, you know, those kind of things. What I've seen most often, and why I thought of this case, is that people will mistake this biceps tendon for the T-band. because they kind of run very close to each other. And they'll mistake that biceps tendon for the IT band. So I had a patient come who's a runner. I'm going to share this video again. So that's me drawing in IT band. This is his biceps femoris that I'm drawing in. Terrible drawing, sorry. I'm going to try again here. There we go. All right, so this here line is the IT band down. This is the biceps femoris coming down, and they attach really pretty close to each other, and I think they're mistaken often. So I had a young cross-country runner come in.
Hey, Chad, sorry to interrupt. We actually can't see your screen right now.
Huh. I figured I was, there we go. Is that better?
Let's see.
Now where'd my video go?
There we go. Oops. And let me go off.
All right, does that work now? All right, so back to talking. All right, so this line right here is basically the posterior aspect of his IT band. These poorly drawn lines here, you can see his biceps femoris tendon in between my fingers. Are we doing all right? I'm hearing lots of, okay, all right, better. All right, so you can see the tendon kind of in between my fingers right there. Basically, those two tissues come down and attach fairly close to each other. And what happened was this young runner came in and he's like, you know, on his intake, he said, I have IT band problems. I've had them for a long time. I had them on my left side. Now I'm having them on the right side. And he comes in and sits down. His dad's in there with him. His dad's in there with him. And he basically sits down and he's like, yeah, it hurts right here. And he grabs exactly where my fingers are. And I was like, that is not your IT band. He's like, oh, no wonder nobody's helped me with this. Because everybody he talked to had just called it his IT band because he was having lateral knee pain. So it's pretty easy conclusion to jump to. But what I want to have happen with this particular lecture is for you to at least palpate the biceps femoris tendon and see if it's the biceps femoris tendon or if it's the actual IT band, right? And that's really all you have to do. You could do resisted flexion of the knee to see if that's painful. You can palpate up into the belly of the muscle itself and see if that's tight, tender, painful. But really, if you just do a pinch test on the tendon and it hurts, and they're like, yeah, that's it, that's where my pain is, then you've essentially figured out what their problem is. They might have other things going on, but they have this going on. And it is another thing that's going to respond well to treatment. Some needles up here, bladder 37, into the tight bandy tissue here, thread along the tendon down here, run some e-stim, do some distal bladder treatment kind of stuff, bladder 57, bladder 58, bladder 60, bleed the jing well to start with, might be a great place to start with this one. And then do the shoe streams. All right, good. Let's go back to my PowerPoint slide. Disable screen share. All right, back to my PowerPoint slide. All right, this is typically just, when you get this particular problem, it's usually a repetitive thing. Other hamstring issues, you can get an acute, injury. You can tear it, you can get, black and blue, all those things. If that stuff is happening, this is, not something that's going to be overlooked. But when it is going to be overlooked is this repetitive trauma. Typically, I see it in runners all the time and in yoga people. I see it in yoga people all the time. There's actually, I wonder if this person is on here, but there's actually somebody who, probably my first person I ever treated for this particular problem, ended up going to acupuncture school. A yoga person who was completely overstretched their hamstrings, having, knee pain, missed a bunch of times, and then, just from palpation, found a really tender tendon, and just needled around that tendon, did this treatment, and you know, thanks to Whit's great ideas, we were able to have a person out, and she is now an acupuncturist. All right. All right, attachments. So where this, you can have problems, you can have it at the attachment down there. You can feel some problems in the belly of the muscle or at the muscle tendon junction. Typically, they might have some pain with resisted knee flexion. And this is pretty old statistic from when we wrote that book, but the biceps femoris is the most commonly injured hamstring muscle, especially the short head of the biceps tendon. All right. This is more like typical hamstring stuff. So sudden onset, muscle spasm and stiffness, acute bruising and swelling, may have heard a pop or a tear, you know, often due to sudden acceleration or deceleration. That's not really what we're talking about, because stuff would never be overlooked. We're talking about the chronic state. Whit, oh, sorry, what is Whit? Whitfield Reeves is my mentor, wrote, who I helped write his textbook. I can't even remember the title of it. the Acupuncture Handbook of Sports Injuries and Pain. Yeah, Jeff is posting a bunch of stuff. Close to the Bone is not Whitfield Reeves. That is, sorry, brain freezing. Yeah, Close to the Bone is a great book, but that is David Legg from Australia. Don't worry, I'm easily distracted. For those of you who had class with me, you know that. All right. Treatment, bladder 67, definitely an idea here. You can see some brilliant, you know, like I've seen as much as a 40-degree change in hamstring flexibility by just bleeding the bladder 67 point. It's not always that awesome, but man, it's worth trying. And you know, sometimes I only get, you know, 5 or 10 degrees, and I'm like, well, that wasn't a waste of time, but it wasn't nothing dramatic. So I'll just move on to the next stuff. But occasionally you get something brilliant out of that. You can see I'm not doing much with opposite side, opposite extremity here. Empirical points. I don't have any empirical points, but I'm sure somebody has some. Shoestring point combination, definitely bladder 65, small intestine 3. I'm definitely using that. Traditional point categories, as I said, bladder 57, 58 are points I like a lot. Bladder 60 or bladder 60 is a possibility for me. Gallbladder 34 is, you know, really close to the attachment there for that tendon. So gallbladder 3 is a must here. And then I'd probably combine that with liver 3. And then they probably have some hip stuff going on with this. So possibly think about opening, you know, going after the die meridian. So, all right. Nothing intelligent to say here. There's my liver 3, gallbladder 34. And you guys are getting these slides, everything except for the pictures. So don't worry if I'm rushing through that. All right. All right, treating locally. Bladder 37, got a video I'll show you of exactly how to find that. But that's like Whitfield Reeves' go-to point for hamstring stuff. So he's definitely going to needle bladder 37. I needle bladder 37 all the time. You're going to come into the Assure points in the tight band tissue, you know, medial or lateral, depending on which tendon we're talking about that's injured. And then you're going to thread needles alongside of that distal tendon. And then this is probably not our problem, but the ischial attachment of the hamstring, you could go up to bladder 36 if that's also aggravated. But if bladder 36 is also aggravated, again, this probably wasn't, you know, overlooked by anybody. Definitely warmed up. I'm going to cruise through this. If it's on the medial side, kidney 10 is obviously a great point. Bladder 40, if you like bladder 40, is a great point in here, but I don't use bladder 40 very often. And I'm not a gallbladder 30 person. I'd rather do Jian Kwa. All right, here's bladder 37. So to find this, you palpate up medial and lateral into this V, and you just keep going up until that V kind of disappears. That's bladder 37. 6 soon down from the gluteal fold. It often lands perfectly, but sometimes people have this close up a little bit earlier. In that case, I use where it closes up, not the measured bladder 37 from down. That's how I do it. That's how Whit taught me to do it. So, all right. So that's bladder 37, and then, sorry, I just realized you guys can't see my cursor. All right. Triangles are motor point locations. X's are trigger point locations. The biceps femoris, its trigger point referral pattern is down behind the knee. So again, like posterior knee pain, think about that biceps femoris. The medial hamstrings refer up just below the glute. All right, let's go to some videos. All right, here's, I got a screen share. Screen share. All right, so here's a hamstring, lateral sides over here. This is running up that biceps femoris. So you're basically going to put a needle on each side of this. And then you're going to palpate up this line until it starts to disappear. And there's your bladder 37. I put in the other hamstring. You could palpate up there. And then this is where that V kind of runs out and you get bladder 37. All right? So 2 needles here, 4 needles on each side of this tendon, run E-stim across it. I'll show you a picture of that. All right, so this is what it looks like once you have it done. So we got bladder 37 here. We have just some Osher, tight tender spots here and here. Okay, I'm needling, that's perpendicular needling pretty much. I'm just palpating, finding that tight tender tissue, and I'm going straight into it. All right, if you're off of the center line, pretty safe in here. You got a lot of muscle tissue and not a lot of other things you need to be too scared about. And then perpendicular with bladder 37, you don't need to go super deep there. You potentially have, some nervous system running underneath that, so you don't want to go smashing into that. And then I basically, as you see again, I have 2 needles fairly close together. I'm just going to hook E-stim up to those tissues, and then I'm going to just get that right into what I think is the most important tissue there. So that's what I want to E-stim, is that most important tissue. All right, and then coming down here, I just have threaded needles right along that tendon. Trying to see if I... Right. On the other video, the full-length video, see me actually needle this and talk you through it. So I'll let you guys kind of go to that. But they're just needled, oblique along the tendon, as close to the tendon as you can get without hitting it. And then you're just going to run E-stim across it. I have 4 needles here, as you can see. You can do whatever combination across those 4 needles you want to do. All right? All right. And then you have your distal stuff going on in there. And then again, like lower leg or leg issues, you got to look at their hips to see if something going on up there as well. All right. I know we should get to some questions here, so I'm going to call that a day as far as the lecture goes. Those videos are on there, and I actually describe what's going on in the videos, so you'll be able to see them. All right.
All right. Thank you so much, Chad. You did a great job. Actually, Chalia wanted to know, in which direction were you needling in that last video?
Yeah, so they were perpendicular. I kind of described it. They were perpendicular into the muscle, and they are oblique along the tendons.
Perfect. All right, so let's get into some questions, guys. So it looks like we have a fair amount of them in our question tab. First one was from Nick, who wants to know when the Pinpoint Performance podcast is coming back.
Good question. I actually just emailed somebody today to see if I could get them to do an interview. So maybe we'll get that going. I'm trying. It's just a lot going on with this and teaching and
conference.
Sports Acupuncture Alliance is got me taking up a fair amount of my time and focus. So really was trying to get a bunch of Pinpoint Performance podcast stuff out, but it hasn't happened. So I will try. It's definitely on my list. I have a lot of great ideas on people to listen to. If you want to, shoot me an email at the team at Sports Acupuncture Alliance. Team at sportsacupuncturealliance.com, and send me an email that just says, like, I'd like to hear Pony Chang, or, obviously that's somebody I'm thinking about. Send me an email, somebody you'd like to hear, and I will try to get in touch with them. If you have a connection to them, definitely send me an introduction email. That'd be great. So I'd like to do more. It's just, challenging to set aside the time. Sorry, next question.
Melanie Miller would like to know, how is the pain presentation here different from chondromalacia?
So chondromalacia is basically a roughening of the back of the patella. It's more of an arthritic condition, chronic. They may have that going on certainly with the PES. Actually, it'd be really common for them to have something like chondromalacia or patellofemoral joint syndrome going on, and also have the PES stuff. If you treat the PES and get that stuff to go away, it'll clean up your picture and you'll have an easier time figuring out the other stuff is. But yeah, that's a whole nother topic. Tough to, obviously couldn't get the two things I wanted to get in time. So, but yeah, that's more of like problem underneath the kneecap and more of a, quadriceps, hips, kind of problem.
All right. Casey would like to know, can a 13-year-old suffering from PES Anserine after a medial knee strain playing basketball 3 or 4 months later?
Could that happen? Certainly. Definitely could happen. This is something that often happens, and it just is a random. Nobody's really like poking around at that bursa to figure out. People making Minnesota jokes here. Yes, hi Minnesota. That's where I'm from, for those of you who don't know. And so, yeah, this could definitely stick around. It sticks around a lot, and then the kid's probably still playing basketball. So he keeps cutting, changing direction, keeps irritating that tissue. But this is one of the most responsive injuries that I treat. I mean, it's shocking if it doesn't get better very quickly. So especially in a 13-year-old kid. Now, the whole issue of do you needle a 13-year-old kid, I'm going to let you make that decision. I'm not a pediatrics kind of person. I'm pretty much scared of anybody who can't sign their own consent form.
All right. Great answer. And then Damien wanted to know, this was probably about the same time that Tracy asked the question, is this based on the Acupuncture Handbook by Whitfield Reeves?
So, there's a hamstring chapter in there, and you certainly could get some of this from that, but this is a little bit of an offshoot from that. And the PES is not in there. I sent Jeff some notes that lays it out a little bit more for you. It actually looks a lot like what would go in the book. If there's ever enough motivation to put out another edition of that, this would certainly be in that book.
Perfect. And then just so everybody knows, I know people have been asking in the chats and in the questions, the slides will be shared. We just have to remove some of the copyrighted images. And then also Chad's going to supply me with a full-length video that will include everything that we saw here today. It might guess about a week or two to get it up on our blog, but just stay tuned for that. Also, he's also going to include those notes that he just referenced, so we'll share all of this.
So I see quite a few people are kind of taking off. If you have questions or you want to find out about the Sports Acupuncture Alliance or anything that I'm teaching, sportsacupuncturealliance.com or team@sportsacupuncturealliance.com. All right.
Perfect. All right. There's a few more questions, but if you'd like, we can share that in the post-webinar recording, so I can just get those sent over to you if that, Chad.
I'll keep answering questions.
You keep answering? All right, perfect. All right, let's go in. Looks like Katrina, if you have an e-stim machine with more than 2 lead inputs, can you stim all of those points at the same time?
I don't. I usually don't e-stim unless it's a really specific case on somebody I know really well. I don't typically e-stim more than 2 things at a time. And that really comes from Whitfield Reeves. Whit, just from now on is Whitfield Reeves. So that really comes from Whit in his kind of experience of, if you got 4 different leads going on at one time, it's just confusing the body. It's his kind of thought process behind it. So I kind of just stick with less is better. And I only will do, typically I try not to do more than, 2 sets total. So I'll do, 2 spots, e-stim for, 8 to 12 minutes or whatever, and then switch to 2 other spots. And then 8 to 12 minutes, and then that's all the e-stim I try to do. I get sucked in occasionally to do more, but that's what I try to do.
All right. And then Nick wants to know, are there any to differentiate bicep femoris tendons from IT band?
I mean, really palpation. I mean, you can go through all the IT band tests, a modified Ober's test, cushion, like, just compress the IT band against the lateral femur, have them do some flexion extension. If they have IT band problems, like distal IT band problems, that's going to be painful. But, then you could also test, the resisted flexion of the hamstring or resisted extension of the hip to see if that causes pain there as well. But, the reason I picked these 2 is because you can really just pinch that tissue or poke at that tissue. In the biceps femoris, kind of one, really, if you just palpate that biceps femoris, it's probably going to be tender on the person who's having this problem. And that'll tell you a lot. They might also have some IT band problems. It's not impossible. So check out both of them.
All right, we're getting close. Looks like Nick would also like to know, is there a way to cite Janet Travell's work that you were referencing?
It is. It was cited on there.
Oh, what?
And that picture, it had it. But yeah, that is just probably too small for you guys to see. But yes, PowerPoint slides. Basically, there was a Janet Travell thing in there, and that's Barbara Cummings, the author or the artist for that. And then there was, also a picture from our book, or Whit's book. I can't have my PowerPoint slide doing, can I? But
I can bring it back up if you want.
Yeah.
Do you want me to bring it back up?
Sure, just for 1 second.
Of course. Give me 1 second. All right. We're at the end, actually, just so you know.
All right, so these pictures that look like this, these are out of the book. Deborah Kelly was out of the Acupuncture Handbook for Sports Injuries and Pain. Deborah Kelly was the artist for that. And then I definitely would like to.
Is it not?
Yeah. So I do have it. If you look here in the bottom corner, definitely, cited. So
perfect.
All
right, it's there.
All right. Go back to questions.
All right. We have 2 more. Ruben would like to know, does the pain have to be on the pes anserine bursa, or can it be located elsewhere on the medial knee?
Well, I mean, you're kind of looking for, I know you're talking about something that I saw posted the other day. Yeah, I mean, you want to find where those tendons are coming down, and, you want to be pretty close to that. But in a chronic case, that bursa can really get pretty inflamed. I've seen it, come down all the way, like, soon past spleen 9, just because it got so big. So anywhere kind of on that tibial plateau, you could be feeling pain from that bursa, but yeah, I mean, if it's not on a squishy bursa and it's not next to those tendons, then then maybe you got something else you have going on. And that tendon, I mean, that bursa does sit often right on top of the MCL, of the distal attachment of the MCL. So it may be MCL, well, would be another thing to think about. You know, there's always arthritis of the knee, you know, medial compartment of the knee that you want to consider too.
All right, and then one more question from Tracy. Can it look like a meniscus issue? Yeah,
I mean, it definitely could look like a meniscus issue. It's basically, you know, the meniscus you mostly feel right on the joint space there, and this would be right below it. But, you know, you're not going to get as much locking. Locking is the kind of, you know, the biggest red flag for a meniscus issue. This will feel like it's giving out though, which is also a meniscus symptom. You know, walking up and down stairs is a problem with this. And the feeling like giving out is a you know, really common symptom, but that's a common symptom for, you know, just about every knee pain kind of thing. So it's not a great, you know, differentiate.
All right, well, that was it for questions. So, I mean, I really just can't thank you enough, Chad. This was extremely informative, and as I've mentioned multiple times, we will be sharing the recording in the next few weeks on our blog. Anyone who registered will have access to the link right after the close of the webinar. We have no unanswered questions, so they are all answered today.
Can I plug one or two things here?
Of course, of course.
I hate plugging, but, you know, still need to do it. So I know this is really soon, but teaching St. Augustine March 9th and 10th. That's St. Augustine, Florida, March 9th and 10th. 9th and 10th. It's a really small group of people, and that's spine and hip, I think. And then I am teaching, I'm not teaching, the Sports Acupuncture Alliance Summit, April 5th through the 7th in Philadelphia. Definitely go to, you know, sportsacupuncturealliance.com for that. And then I'm teaching in Wyoming for any of you people out west. I'm teaching in Wyoming May 4th and 5th. And I think Jeff will probably include this, but you can shoot an email to their president at sweetgrassacu@gmail.com. I'll have Jeff send that out. But it's basically the Wyoming Acupuncture Association is putting that on. So it's basically I get to go do some rock climbing before my next kid shows up.
Awesome. Well, just so you guys know, the links are in the chat tab for all of this. So Chad's teaching experience, the Sports Acupuncture Alliance, and I will share afterwards the email for the Wyoming Acupuncture Association. I mean, anything else, Chad, that you wanted to say?
Somebody just asked if I'd come to North Carolina. Yeah, why not?
All right.
So, John, email me.
Well, I was actually going to mention all of these things in my outro, so Chad took care of that for me. LASA OMS is the sole sponsor for the Sports Acupuncture Alliance Summit. We are going to be there. We're going to be offering great discounts, tons of product samples. We'll have our new ProMax needles, which are the new sport therapy needle by DDC, the new Sarin G-type needles there as well. Thank you to everyone who joined us tonight. Thank you, Chad, for everything that you've done, and we will see you guys next time. All right, good night, everybody.
Hold on. Don't cut me off. Katrina, I would love to come to Alaska. I mean, it's a huge part of my acupuncture story was a huge car accident in Alaska. But with a new kid coming, I don't know how soon I'll be able to get there, but someday I would love to Alaska.
All right, let's get Chad to Alaska. All right. Well, thank you, everybody. Again, have a great night. I hope to see you guys in Philly for the Sports Acupuncture Alliance. Go to Florida, Chad's class in March. And everyone have a great night.
Thank you, guys.
Thank you. All right, good night, Chad.
Good reference for Eastham.